Well, hello. This is Dr. Isabelle Amigues, and welcome to the UnabridgedMD Podcast. Here we explore inspiring stories, practical tools, and expert insights for living a healthy life. Whether you're a patient, a healthcare professional, or simply curious about healing, you are in the right place. And as always, if you are looking for something that's so much bigger than just a rheumatology practice, please come check UnabridgedMD, as we are the right place to get you to remission with the least amount of medication. With that said, let's dive in. Okay. Well, such a pleasure. So today my guest is Lindsay Arnold. She is a physical therapist who has also got out of the insurance system. And I think we should just go directly into this and then we'll see where our conversation is taking us. And I definitely want to talk about what you offer to patients. I've myself experienced it. I've had patients that are seeing you. So yeah, why leave the insurance system?
Well, thank you, Dr. Amigues, for having me on the podcast. I'm very excited to be here. So that is it's a big question, and it was something that I did not take lightly. It took me a long time to arrive at the decision to leave the insurance system. So it had to do with kind of a gradual change over the years. When I first started in physical therapy, I felt like I did have adequate time to treat patients. I felt like I had breaks in between. And that little by little got eaten away. So I was seeing more patients, less time, both for the patients and for myself. So, it got to the point where I wasn't getting any lunch breaks. It was difficult for me to go to the bathroom during the day. And I just really couldn't treat patients the way that I wanted to treat them. So I was getting further and further away from why I became a therapist in the first place. So, and then I had my daughter about 4 years ago, and I don't want to say it was an immediate, but, things change when you become a parent. And I really wanted to have more flexibility at that point. And that was kind of the final push for me to get out and go on my own.
And what have you seen so far being on your own, like in terms of outcome for patients? What's the...
Yeah. So patients get better quicker.
Yeah, right?
It takes them less visits to get there.
Yeah.
Because I don't have somebody right behind me. I have more time. I spend, for treatment sessions, I spend usually an hour. And for the initial evaluation, it's anywhere between 60 and 90 minutes, sometimes longer, depending on the complexity of the case. But because I'm able to spend that amount of time, and I'm also not worried about, for example, dry needling is something that not all insurance companies cover, but I incorporate in my practice, not with every patient, but a good chunk. And that's something that I'm allowed to do now. I don't have to worry about, do I need to get pre-authorization? Is it going to be covered at all? So I just move forward based on what the patient needs. And so because of that, the outcomes have been a lot better.
Yeah, I can totally relate to this.
I bet.
And in terms of, so there's the outcome for the patient. And then in terms of your life, what has changed?
Well, I'm seeing less patients. So, that's, it's good and bad, right? So I think less patients, I'd like to see more. But I want to cap that at a point where I still have a life and I still am able to, do all the non-clinical things that I need to do. I need to chart on patients. I need to make phone calls to doctors. I get my lunch, I get my bathroom breaks, and I'm also able to pick my daughter up from school.
Yeah.
So
and I think that's so important. And it's funny, recently I had an encounter with someone that couldn't really understand the principle of non-insurance based practice. Like, it's a patient and it didn't understand. And I'm almost come at this point of like thinking, don't they want their physician, their physical therapist, their treatment team to be happy, to have enough energy inside of them, love, I consider it love personally, love inside of them to care, versus I'm feeling rushed. And Oh, it's actually really, really fun. I was just talking to my mentor. He's a 85, almost 86-year-old man.
Oh, wow.
He's a physician back in France, and he's my mentor. I adore him. He's an author and a pediatrician of formation, education, but works with adult. And he was telling me, so he has issues. I mean, if he were here, I would send him to you for sure. Oh. But basically, he did this program, and he was telling me, when I did this program, they would see me 3 times a week, but basically you have one physical therapist working with 3 or 4 different patients. Right. They don't really, they don't care. And really, the word "don't care" came at least 5-6 times since he started this program. So now he's back to the person that he had before, and that has his own practice. And he was like, yeah, I mean, one session and I was feeling better, and I had better outcome already. I felt energetic and so on. And that's what I thought. I was like, well, you want someone that cares because they already care for themselves, right? Right. We are better because we care for ourselves. I do believe that. Yeah. Right.
Absolutely. Yeah, you just have more of a reserve. And I think that when I was in the insurance-based system, and I was there for a long time, I mean, I was there, I've been a therapist since 2010. So, just the past year, I've had my own practice. So, over 10 years. And I think that I just didn't have the reserve at the end of the day for myself, for my family. But by the end of that last patient, I knew I had at least an hour or 2 of paperwork because of the volume of patients that I was seeing. And then I still had to go home and be a person and be a wife and a mother. And I just think that allows me to recharge, not being so back to back, not having so much volume, and not just recharge, but, I think I never realized how difficult and wonderful, but difficult it is seeing patients and really caring, right? You give a part of yourself.
Totally.
When you treat. And so you give and you give and you give all day. And then by the end, there's just nothing left. So I didn't want to feel that way anymore.
Yeah, absolutely. Yeah. And I think what's really valuable here is that you realized it. There's so many healthcare workers that don't even realize that they're burnt out. Right. And the only thing they want to do is get out of the room. And as a patient, you're like, I don't want to be here. Yeah, I just don't want to be here. If they don't want me to be here, why should I want to be here, right? And so you can't offer this. Right. So thank you so much for sharing so much about this and your experience. What's your zone of genius in physical therapy? I mean, I have some ideas, of course, but I love asking this question. What do you like the most?
What do I like the most? When I first started, I really... I went into a neurological setting. So I worked with folks that had traumatic brain injury and post-stroke, spinal cord injury. And I loved that population. But as I kind of progressed through, my neurological training, I started to incorporate more manual therapy techniques, so hands-on. And I always kind of thought that's just going to wear out my joints, and I don't want to wear out my hands. I don't want to do that. But, there's ways to do it safely. As a PT, I think I'm best suited to figure out my ergonomics in that situation. Yeah, right. So I can kind of, I can figure that out. Body mechanics help, but, I really like hands-on. I like the manual therapy. I think not only
patients love it.
And I think, the rapport that you establish with a patient, when you do whatever, it doesn't have to be anything in particular, dry needling, massage, joint mobilization, Graston, whatever. I think it establishes a rapport. So whether a person primarily needs balance training or, if somebody for example, I see a lot of patients, older patients with fall prevention. or treating falls. But maybe they have a problem with their knee, and that's part of the reason why they're falling. Well, a lot of times if they can't straighten their knee because, maybe the tibiofemoral joint is just, it's stiff. If you do some just gentle joint mobilizations there and the knee straightens a little bit better, the knee is more stable, it's less painful, and then their fall risk is lower. So I think that, I've started to kind of think out of the box in terms of when manual therapy can be applied, even if that's not the primary reason that they're coming.
I love this. I really do.
Yeah, it's fun.
So to jump into inflammatory arthritis or rheumatologic condition, where we actually need a lot of physical therapy, what's your approach to folks who have an inflammatory arthritis? How do you approach this?
Yeah, so more rheumatoid?
For example, psoriatic arthritis, rheumatoid arthritis.
Sure. Yeah, so rheumatoid arthritis, there was a clinical practice guideline that came out within the past 5 years. I can't remember exactly what year, but so exercise prescription is a primary focus. And so, there's kind of a very specific framework that they suggest. So it's based on the FIT principle, or the FIT framework, shall we say. So FIT stands for frequency, intensity, type, and time. And so the frequency, they're really recommending exercise every day. So resistance training a couple times a week, aerobic 5 days a week. The intensity should be as intense as tolerated. So, when we're talking about aerobic, 50 to 70% of your max heart rate. We want to be 60 to 80% of your 1RM max for resistance training. And then, the type of exercise, it's whatever exercise. Like I always say to the patient, what do you like? What do you like to do?
Exactly.
And I think that's something that gets missed. You can go completely with the research, but everything needs to be individualized.
Yeah.
And so if they don't like it, they're not going to do it.
I agree.
I mean, it's the same thing with me. If you told me to jump rope for 30 minutes, I'm not going to do that. I hate that. So you have to meet them where they are. But ideally it's some sort of low load, low joint load. So cycling, swimming, walking. And then the time, 30 to 60 minute bouts is really what's recommended, but obviously you titrate that based on where they are. And then, I just talked about loving manual therapy, but, I think the clinical practice guideline kind of, I don't want to say it poo-poos it, but it just doesn't stress it. And it says, exercise prescription should be the main focus of rehab for RA. And then also gauging the exercise based on pain response. So if a person exercises and the pain is worse, for 2 hours after stopping the exercise, then it needs to be modified. But again, in terms of manual therapy, I'm not going to completely rule that out. I think it's person to person, if
and I'm assuming also needed.
If you need it, then
absolutely.
they need it. Yeah. So, you just have to be careful with RA, nothing aggressive with the neck, obviously. But, and kind of looking at all the joints, because obviously it's systemic. So you can't just say, your knee's bothering you today. That's the only thing we're going to look at. So you look at all of it. You look at the whole person.
Yeah, I love it. And I think some people don't realize that. So there's very often this question of like, when I have rheumatoid arthritis, it's not yet in full remission, which is our goal. What should I do with the joint? And I always say, no, you need to move them because the risk, so maybe you can explain what the risk is. I mean, as a rheumatologist, I know my risk, but what's the risk if you don't move your joint?
So the joint can become contracted. I mean, if, I was giving
what
an
is
example,
contracted? Just for someone that doesn't know.
Sure. So, so if a joint is contracted, like let's say we're talking about the knee, and I was giving the example, I'll kind of go back to the example of the individual that, had a balance problem and they couldn't fully straighten their knee. So a contracture occurs either because of, an articular contraction where the actual, like there's scar tissue that builds up from the inflammatory process over time. And that scar tissue does not act like like the original tissue that was there. And so it's just not as well vascularized. It's not as extensible. And so if you just kind of sit in a chair all the time, for example, and you don't straighten your knee all the way, then the joint, that tissue, that scar tissue is going to form in the position that it's in the vast majority of the time. So that's one thing. And then soft tissue too, let's again, take the knee, for example. If you're sitting in a chair all the time, your hamstrings and your calves are going to be incredibly tight. So you can get a soft tissue contracture too. But RA, we're primarily concerned about the joint itself. And when you exercise, there's more nutrition that gets to the joint. There's more oxygenation and there's more fluid. And so things are more extensible.
Yeah, I fully agree. I remember when I was in New York, having seen a patient that had not been treated for RA because she was in another country. So she came to New York. And I remember she was so contracted. And it turned out that she was putting pillows under her knees and under her arm, but then she couldn't really move them anymore. And it's sad because you think, oh, well, not only do we have really good treatment nowadays, and we could have prevented that, but we could also have prevented the retraction. And now it's going to be a lot harder to take care of this.
Harder.
Yeah, exactly. Maybe like surgery and so on. But that's the truth is that I don't see that often anymore. It's certain type of population that we see this on. So I really think that that's important for folks to realize that, yes, there is pain, there is inflammation. You don't want to go crazy on them. Something that's gentle, work with a physical therapist that specialized in this, right? Someone like you. Absolutely. And for someone that wants to just prevent, right? Like it's just about prevention.
Yeah.
What would you like if, let's say we are, in a place where we can have prevention? What would you recommend, basically, from a physical therapist perspective, right?
For RA or just in general?
Inflammatory arthritis, I think, because that's really like the main area of UnabridgedMD, but in general also, because that's also super interesting.
Yeah. So, in terms of RA, the exercises, if we're talking about exercise prescription for, prevention, I think that one thing that wasn't mentioned necessarily in the clinical practice guideline that I read was balance training. I think balance training should be
balance or bones?
Balance.
Yep.
Yeah. Balance training is something that I think that, we should all be practicing earlier than we think.
Yeah.
So, a very simple test that somebody can do on their own, it takes a minute, is stand on one leg for 10 seconds. And so if you can do that, without holding on to anything, without hooking your other leg around and using external support. So if you can stand on one leg for 10 seconds on both legs, it drastically reduces your risk for falls and it improves your mortality outlook. So, it's my go-to test that I go to everybody, even if they're not having balance problems, I just check it and you'd be surprised. A lot of people can't do it. So, I have suggested, and there's, I forget, there's some Instagram person out there, but he started having people like stand on one leg to put their socks and shoes on.
Yeah.
And I love that. I think that's so great. And it's a very functional thing to do. We all have to put our socks and shoes on. Why not do it on one leg?
Yeah.
People talk about, like, I have patients come back and say, yeah, I do it when I'm brushing my teeth. Okay. But like, just incorporate it into your daily life. Don't make it an exercise per se. Just do things on one leg. So that as a prevention strategy would be a big deal.
I love this.
Yeah. And then in terms of, the resistance training that they talked about in the practice guideline, resistance training doesn't have to be like standing there doing bicep curls. I would, again, kind of looping it back to function. Can you get in and out of a chair? Can you get on and off the floor? Can you get in and out of bed? If any of these things become difficult, like floor transfers specifically, I think everybody should be able to get on and off the floor because, for cleaning purposes, just everyday life, like, I don't know, whatever, you got something under your bed, you want to go get that. Or, if we inadvertently do fall and find
Yeah.
ourselves on the floor, assuming we're not hurt and you can get up on your own, that would be ideal, as opposed to calling the EMTs or relying on a spouse or a family member. So, some exercises around that. If you find yourself, I can do it, but maybe it's a little hard. If it's hard for you to push up, like if your upper body is a little bit weak, stand against a wall and do wall push-ups, do table push-ups, and then progress to the floor. Squats, but if squats are uncomfortable, if your knees bother you, then you can start off with something easier. You can start off with bridges. You can start off with, laying on your back and kind of raising your pelvis. That's what a bridge is. And then, strengthening some of the other muscles around the hips usually are pretty weak on most people. So laying on your side, doing side-lying leg lifts, going up on your toes, transitioning on your bed from all fours to like a tall kneeling position. You can kind of break that function down and pick the things that, pick the parts of it that you're having the most difficulty with. And that counts as resistance training. And then once you can get to the point where it's easy to get on and off the floor, do that. It works your core. It works your arms. It works your legs. Do 5 to 8 repetitions of those, a few times a week. That counts. So I think, being really creative in how we design resistance training programs as a preventative strategy to make sure that people can do these basic functions for as long as they can, given the limitations with their joints.
I love this.
Oh, good.
Yeah, I love this. So this is a podcast about hope, and so I love sharing stories.
Yeah.
Can you tell us a story that happened to you recently or not so recently, related to a patient where you saw a really incredible improvement?
Yeah. So it's a long journey. So I have actually a husband and wife team, I call them, that I worked with when I was in the insurance-based system. And they both had very similar injuries, but not at the same time. So the male patient was biking overseas in Europe, and he was on an e-bike and it fell on his leg and he fractured his tibia. And his wife, I can't remember how long it was between their injuries, but anyway, very similar injury, but different mechanisms. So she was skiing and fractured her tibia as well. And I ended up seeing both of them, and it took a long time to recover from those injuries. And obviously they were very active to start with. Yeah. So, they didn't want to just be able to like walk to the mailbox. They wanted to go back to those high level activities. Absolutely. So, the higher the level of activity, the longer it takes. So, I worked with them, in a physical therapy setting. And then when I went off on my own, they came with me. And I've been working with them. And recently, maybe about a month ago, the three of us went on a run together.
Oh, that's so cool. I love it.
Yeah. So we went along the Cherry Creek Trail and we went on about a mile run. So it was great.
Love it. Yeah. No, absolutely. And, it's funny, but it's really about this idea that there's nothing that our body cannot do, right? Like if we put our mind and our work towards it, I do think that the medicine nowadays is very powerful and we can really help.
Yes.
And with all additional techniques, there are so many additional techniques now. So I think that that's very exciting.
Yes.
So Lindsay, if we wanted to work with you, and
Sure.
my patients know already,
Yeah.
but for those that do not know yet,
Yes.
Where can we find you? How do we get in contact with you? Tell us.
Sure. Yeah. So my cell phone, my email, you want me to put those in the show notes?
We will. Yeah.
Sure.
Absolutely.
Yeah. So when you call me, I'm a one-woman circus, so you get me. And then my email, and my office is located at 825 East Spear Boulevard, Suite 203 in Denver. So it's right by Alamo Placida Park. And I'm there some days during the week. And then I also do mobile visits too. So, if patients would prefer that I come to their homes, absolutely fine.
Mm-hmm.
Yeah.
Wonderful. Do you have a website that
I do.
What is your website?
Goodmovept.com.
Good Move PT. So everyone, check it out.
Yes.
Well, thank you so much, Lindsay. It's always a pleasure to talk with you, and it's really wonderful to being able to share, your passion here. Everyone, go and check Lindsay's website. You will see kind of like really where what you can do with her. I would recommend even just to check it out, just to see. We all have recurrent injuries after a certain age that we can prevent.
Yep.
And so, if you are in Denver, don't hesitate to contact Lindsay. Well, thank you so much. And everyone, we will see you in another UnabridgedMD episode. Don't hesitate to share this episode if you thought that it was useful for you. So there is someone else that can find valuable information. Have a wonderful day. All right.
Thank you very much. Yay, that was so fun.
Well, thanks again for tuning into the UnabridgedMD podcast. Be sure to subscribe so you can be notified when the next episode is up. And as always, if you think that this would be helpful for a friend or a family member, please share. Wishing you wellness. Until next time, take care.